In this presentation, I'd like to discuss oxygen toxicity because that is a relevant consideration either when breathing oxygen in the form of air under pressure underwater, or when using surface oxygen, or in the case of the treatment of decompression illness, oxygen under pressure. So one needs to know something about the limitations and safety issues related to oxygen. Now, in general, one could say that life walks a precarious path between starvation of oxygen, or asphyxia, and rust and ashes on the other side, which is oxidation. And so we've got a supply and demand issue that we need to consider within the body, and within that spectrum of too little and too much, we need to contend with so-called oxygen toxicity. And I'm going to review some characteristics of oxygen, the type of oxygen toxicity one can have, the effects of elevated oxygen, and then of course how we manage or avoid oxygen toxicity. Now, oxygen is quite unique in terms of its chemical structure. It's quite reactive. Now, the most stable form of oxygen is in combination with hydrogen in the form of water. And because that's a very stable form, the result is in forming water there's a tremendous amount of energy release. In our cells, in the so-called mitochondria, oxygen and hydrogen are combined to produce water, and the energy that is derived from that is used to produce the cell's energy, which is also called ATP. The dilemma is that in the process of converting oxygen to water, there are actually 4 different steps, and each one of these steps, in other words, the incomplete transfer or change from oxygen to water, represents a so-called intermediate form of oxygen that is simultaneously more and more reactive. And they are in sequence superoxide, hydrogen peroxide, and finally hydroxyl. And these are called reactive oxygen species, or oxygen radicals is the other word that is used. And they ultimately are the mechanisms through which one gets oxygen toxicity. Water, as I said, is the perfect marriage, and the intermediate forms can interact with various parts of the body. And as they do that, they can either break things down, they can disrupt the process of producing chemicals within the body, and even damage DNA. So oxygen can be potentially toxic. Now, as I mentioned, we've essentially got a balance of supply and demand on the one hand, and then the oxygen defenses versus the reactive oxygen species on the other side. And as we look at the range of oxygen that we breathe or could be exposed to for a reasonable period of time, we basically have a range from 0.1 atmosphere to all the way through to 3 atmospheres. So in other words, 1/10 of an atmosphere of oxygen. Bearing in mind that when we breathe 21% oxygen in 1 atmosphere, that's 0.21. So in other words, 10% oxygen at 1 atmosphere would give you 0.1, and that would maintain consciousness for a limited period of time, several minutes. Conversely, if you go all the way up to 3 atmospheres, then usually one would develop an oxygen toxicity seizure within about 45 minutes. There's a lot of variability, as we'll explain in a moment. But that's the range that humans can tolerate. Now, of course, when we introduce someone to an environment underwater, there's an additional concern in that oxygen toxicity seizures are likely to result in drowning. So clearly you'd want to avoid oxygen toxicity seizures underwater. When we look at oxygen toxicity, not all organs of the body are affected equally, and not all of them are affected under the same conditions. It is impossible to poison the brain with oxygen at 1 atmosphere. You need oxygen under pressure, in other words, more than 1 atmosphere of oxygen, in order to produce disruption of the brain circuitry to the point of developing a seizure. However, pulmonary oxygen toxicity, such as you might get in an intensive care unit, can actually develop at 1 atmosphere of oxygen after 24 hours. So it means that the lungs limit long-term exposure to oxygen, whereas the brain limits high pressure of oxygen delivery. In practice, we've got 2 clocks that run as soon as we breathe oxygen under pressure. The so-called pulmonary oxygen clock starts ticking as soon as the oxygen that we breathe increases beyond 50% at 1 atmosphere, or if you like, half an atmosphere of oxygen. From that point, our lungs start becoming poisoned, And depending on the partial pressure of oxygen, the rate in which this poisoning occurs will of course vary, increasing exponentially, as we'll show you in a moment. Central nervous system oxygen toxicity, on the other hand, only becomes a risk around 1.6 atmospheres, and to be conservative, some manuals will use 1.4. But in practice, mostly we find that oxygen toxicity seizures are unlikely to occur under 1.6 atmospheres. So that means basically you could breathe 100% oxygen at 6 meters underwater without running too much of a risk of central nervous system oxygen toxicity or oxygen toxicity seizures. However, to be on the safe side, even there we impose certain time restrictions. Paul Baer poisoned himself at 4 atmospheres using very primitive equipment and recorded the so-called Paul Baer effect, which is oxygen toxicity seizures. Fortunately, since then we have learned that a single seizure doesn't cause brain damage or ongoing epilepsy. However, you cannot expose a person indefinitely to oxygen under high pressures by, for instance, suppressing epileptic seizures. In other words, even if you put a person under complete anesthesia, if you expose them to very high levels of oxygen, you will still ultimately get brain damage, even if you suppress the seizure. So the point of the fact is, suppressing seizures isn't the issue, it's the oxygen dosing that one needs to control. Now, in terms of risks for oxygen toxicity seizures, there's a significant difference between the risk of a submerged diver and a patient in a chamber. For one, in the underwater situation, a diver is more likely to die by drowning if they were to have a seizure. In addition, you've got exacerbating factors such as cold, being immersed in water, exercise, buildup of CO2, the additional breathing resistance by the equipment, the fact that you can't prevent it, and therefore you have to minimize the risk. So one tends to be very conservative when it comes to oxygen partial pressure in water. On the other hand, when you have someone in a hyperbaric chamber, it's usually in order to give them the greatest benefit of oxygen dosing, and for that reason one is prepared to take a slightly greater risk. And also, if someone were to have a seizure in a chamber, you're usually able to deal with it. Plus, it's a breathable environment, so the person will ultimately resume breathing when the seizure ceases. So for that reason, we're able to go up to 3 atmospheres of oxygen, and the way in which we reduce the risk for seizures is usually by providing air breaks, in other words, interruptions of oxygen breathing to allow the brain and to some extent the lungs to recover. Central nervous system toxicity in diving presents a unique challenge. Essentially, one needs to remain between 1.4 and 1.6 atmospheres, which gives one a range of between 150 and 45 minutes, depending on the pressure one chooses, and this would be achieved breathing air at between 56 and 66 meters, on nitrox 32 or nitrox 1 between 34 and 40 meters, nitrox 2 which is 36% at 29 to 34 meters, and breathing pure oxygen between 4 and 6 meters seawater. On top of that, one needs to avoid exertion. When we provide oxygen in a hyperbaric chamber, however, we usually work between 1.5 and 3 atmospheres with a range of between 2 hours at 1.5 and 90 minutes without air breaks at 3 atmospheres, which would be an extreme situation. And those would be worst case scenario for gas gangrene and carbon monoxide, where we'd go all the way to 3. Diving disorders and bubble disease, that we would use 2.8. The usual run-of-the-mill hyperbaric oxygen treatments, which would be at 2.5, the wound healing protocols at 2, and in some cases brain injury and neurological problems are treated at 1.5. So we work well outside the range that would be acceptable in water, but it's because it's used for a therapeutic reason and because the risks of seizure in terms of resulting in secondary problems is so much less in a hyperbaric environment filled with gas rather than it would be in water. The most common first symptom of oxygen toxicity is nausea and sometimes vomiting. So someone breathing oxygen under pressure complaining of nausea should immediately alert you to considering possible oxygen toxicity. Unfortunately, this is often immediately followed by seizures, so there's not a reliable warning system. Nausea that occurs at pressures greater than 1.4 atmospheres, in which the exposure has been more than 15 minutes, should always potentially be thought of as being related to oxygen toxicity, and possibly a risk factor for the pallbearer effect. This is just an acronym that we use to train people on it. Convented is sometimes the way we remind ourselves that convulsions may be the first warning sign, but the vented stands for vision, tunnel vision, spots or flickers, ears, which may be ringing, nausea, twitching lips, irritability or sudden change of personality or anxiety, and finally vertigo, which, to make the acronym, is called dizziness. So vision, ears, nausea, twitching, irritability and dizziness, with convulsions unfortunately often being the first manifestation. Now, when managing oxygen toxicity seizures in a water environment, the greatest risk is drowning, followed by the potential for arterial gas embolism and lung overpressure injury. In a hyperbaric environment, drowning of course isn't a problem, but then the actions would largely depend on the reason for the person being in hyperbaric oxygen to begin with. If it's a training dive and there's no reason to consider decompression obligations, as soon as the seizure has terminated, one would be able to decompress the individual. The same if it's a routine indication for HPO that could just as well wait for tomorrow. If it's a life-threatening indication, such as gas gangrene for instance, then one may need to suppress the possibility of seizures simply because the oxygen is life-saving. And similarly, although for a slightly different reason, if a person is suffering decompression illness and they develop oxygen toxicity seizures, you have the quandary of not wanting to decompress them, not only because it might cause a lung overpressure injury if they were holding their breath during the seizure, but also because if they have gas bubble disease, this would be made worse. So one usually then simply removes the person from the oxygen breathing source. One allows them to breathe the chamber air for a period of 15 minutes after the last symptom has subsided, and then you re-enter the ongoing treatment at the point where it was interrupted. So it's basically as if time stands still from the point they stop breathing oxygen until 15 minutes after they had no further manifestations of oxygen toxicity, and one then resumes the treatment schedule from the point where the interruption occurred. The most important thing to remember is never decompress a patient during a seizure. To do that is to run a very high risk of pulmonary overpressure injuries. If a seizure occurs during decompression, in other words, whilst one is changing depth in the chamber, then one should immediately stop further decompression until the seizure has ceased. Now, in addition to central nervous system oxygen toxicity, which might be prevented through risk factor assessment such as fever, monitoring for the vented or convented signs, using antioxidants like vitamin E, fever-breaking medication, or prophylactic medication like Valium under very selected circumstances, providing air breaks or intermittent oxygen exposure, and of course limiting the time or the partial pressure of oxygen selected. These might all be variables one can include to reduce the chances of oxygen toxicity affecting the brain. However, when it comes to the lungs, things are slightly different. Essentially, oxygen causes almost a type of chemical pneumonia of the lung, and the longer one remains on oxygen, the more severe the effect. If you breathe more than 50% oxygen at 1 atmosphere or 0.5 atmospheres, eventually the lungs will show signs of oxygen toxicity. And over a period of time, greater when one is breathing a higher partial pressure of oxygen, the lungs will deteriorate to a point where one has lost 10% of the volume that you can voluntarily breathe in and breathe out. That, for a variety of reasons, is considered to be the threshold of acceptable oxygen toxicity in a hyperbaric setting. So, in order to avoid this, one can have various time and pressure intervals to prevent both the brain from becoming toxic or resulting in seizures, and the lungs becoming intoxicated with oxygen. How divers differ from, for instance, ICU patients is that an ICU patient is typically on a ventilator and simply won't be conscious in order to complain. A diver in a chamber undergoing recompression will actually start complaining about burning in the trachea or the windpipe, especially with deep breathing, tight-chestedness, substernal pain over the breastbone, a sense of breathlessness, and of course, as the oxygen partial pressure increases, so the symptoms may also intensify. So these are warning signs. They are unlikely to occur early in a treatment unless a person has received extended periods of surface oxygen and on top of that gets recompression treatment. Now, one can do chest x-rays and lung function tests and even very fancy assessments, but for the most part they are not particularly helpful, and one relies largely on the dose exposure of oxygen to try and deal with the side effects. Of course, if you are forced to provide multiple treatments, one would ultimately have to look at these special examinations, but for most recompression applications it's not necessary. This is not a particularly good quality X-ray, but it shows you that essentially oxygen toxicity looks a little bit like pneumonia. The treatment, of course, is to limit the amount of oxygen exposure, and as far as the lungs are concerned, this is treated like a pneumonia, but prevention is better than cure. The normal exposure limits to oxygen we've already discussed, but just to have them in a single table. However, of course, divers typically don't stay at a single depth, and there may be multiple gases, and there may also be decompression gases that are used with higher partial pressures of oxygen. So essentially, to calculate the so-called units of pulmonary toxicity, there is a way of multiplying the partial pressure of oxygen, which is derived from the percentage or fraction of oxygen multiplied by the pressure under which it's breathed, and a corresponding toxicity factor, or so-called Kp factor. And looking that factor up on a table, you can basically calculate what the equivalent exposure is when someone breathes oxygen under pressure. Now, the maximum exposure that is acceptable is 1,440 units, and that translates to a full 1 day's worth of breathing 100% oxygen at 1 atmosphere. So 100% oxygen at 1 atmosphere is calculated as 1 unit of pulmonary toxicity per minute. And after a full day, that amounts to 1,440 units because of the same number of minutes. Now, when you breathe oxygen at greater pressures, you will accumulate these units more quickly using the Kp factor that we showed you a moment ago. And therefore you can compare the relative toxicity at pressures different from 1 atmosphere. And that's the basis of oxygen tolerance units, which is another name that's used for units of pulmonary toxicity, or UPTD. And 1,400 units usually translates to the threshold that I mentioned earlier, which is a 10% reduction of vital capacity. In other words, the volume of air that you would be able to breathe out after a full inhalation. Once we exceed approximately 2,200 units, then we approach a 20% reduction of vital capacity, and some of the effects may become irreversible. So clearly the objective is to try and stay within 1,400 UPTDs. How do we do that? Well, intermittent oxygen breathing, or avoiding continuous exposure to oxygen that would accumulate more than 1,440 units per day. What does that mean in practice? Well, a standard oxygen treatment amounts to approximately 600 units. So, the best combination of surface oxygen and recompression would translate into no more than 6 hours of continuous 100% oxygen at the surface, followed by a full table 6 of 2.8 atmospheres of oxygen over 4 hours and 45 minutes. Individual susceptibility to oxygen toxicity varies, which means in the same individual, the same exposure to oxygen may produce different toxic effects from day to day, and also there is variability between individuals. So one individual may develop a seizure whereas another would not under the exact same conditions. So that concludes this presentation on the potential problems related to oxygen breathing. In summary, surface oxygen is appropriate for the treatment of diving-related problems, and up to 6 hours continuous oxygen breathing, if one anticipates that the person will then be receiving recompression, would not cause any undue damage to the lungs that would impact hyperbaric treatment. However, if a person is going to have a significant delay before getting to a recompression facility, one could easily go as long as 16 hours. Recompression accumulates approximately 600 units of pulmonary toxicity, whereas breathing 100% oxygen for 24 hours produces 1,440 units. That represents about a 10% reduction in the amount of air the person can exhale after maximal inhalation, and represents a reversible pulmonary damage. The more significant concern, certainly in terms of in-water exposure to oxygen, is oxygen toxicity seizures, for which the threshold is 1.4 to 1.6 atmospheres over time. Clearly, the risk needs to be minimized by maintaining relatively short exposures to those partial pressures when breathing oxygen in a mixture or in pure form underwater. The signs of oxygen toxicity unfortunately may start with convulsions, but nausea is a telltale sign that occurs in about 36% of cases and should always be a potential warning sign. If a person does develop an oxygen toxicity seizure and they're in water, protecting them from drowning is the most important priority, and thereafter trying to avoid a lung overpressure injury whilst one returns them to the surface. If a seizure occurs in a chamber, one does not decompress the chamber. In other words, if you were decompressing, you stop, and if it happens whilst one is at a stable depth, you don't change the depth, but you would remove the oxygen breathing source to allow the oxygen to drop off and the seizure to terminate. And then, based on the reason why the person is being treated, one might either decide to either remove the person from the chamber or interrupt oxygen breathing until all the symptoms have subsided, add 15 minutes, and then continue the recompression protocol at the point where the seizure occurred. And under very, very rare situations, one might choose to suppress the chances of a seizure by providing an intravenous dose of Valium or diazepam. But this should never be undertaken without the express instruction of a knowledgeable diving physician under very, very carefully controlled and selected conditions. Thank you very much.